guys, what is up? This is Larry. So today we're going to be doing something that you guys asked for. You guys wanted a series on heart rhythms and all different types of heart rhythms. So what we're going to do today is going to be part one of our series. Today we're going to be talking about AFib, one of the most common arrhythmias that you're going to come across in healthcare. So what we're going to do, we're going to go over kind of a basic overview of AFib. We're going to go over some of the medications that you treat with. But then we're going to take a little deeper dive into AFib in a critical care setting and some of the things that you may not have thought of or known that can cause AFib in critically ill patients. And we're going to go through those step by step. So let's get into it. Let's get to it. Alrighty guys, take a look here. Normal sinus rhythm on the left, AFib on the right. So look at your rhythm first. On your normal sinus rhythm, you've got beautiful P waves before your QRSs. Now, peek at that AFib. There's no beautiful P wave involved. It's just chaotic artifact. So look down at your heart diagram down there and you'll see on normal sinus, you have a clear signal leaving that sinus node going down to the AV node. And it works beautifully through the atria and down through the ventricles, just like it's supposed to. But if you look at the sinus node and what's going on in those atria on AFib, it's chaotic. It's like a ping pong ball of energy just bouncing around, which makes sense when you look at your rhythm strip there. Now the ventricles are feeding fine, but they're just irregular because every so often one's going to go through and then another one. And that's characteristic of AFib, is it's going to be irregular. All right, so now that you saw an overview, let's look at live action. Here's a normal sinus. Beautiful rhythmic motion here, just flowing from top to bottom. Now, let's look at AFib. Look at all those chaotic motions from up top. It's firing all over the place. It's firing when it wants to. This is typical AFib, and this is kind of what it looks like from a motion standpoint. Why do we worry about AFib so much? Well, clot formation. Here's a great example. Atria contracting intermittently, slowly, and not completely, forms a clot, sends that up to the old brain spine dangler, and boom, debilitation. So I just got word, we've got footage inside of the atria and the ventricle in somebody with normal sinus. Let's take a peek at it real quick. Wow, truly amazing footage. Now, I've also taken word that we've got footage inside of somebody with AFib RVR. Let's take a peek. Wow, that looks like a rager. All right, let's continue on. All right, let's talk about signs and symptoms. So palpitations, irregular heartbeat, to me, always at the top of my list. Irregular heartbeat goes with AFib like peanut butter and jelly. Like, it's always irregular, and it's going to cause that pounding or fluttering feeling. So those are always at the top. Dizziness, fatigue, shortness of breath, chest pain, and sweating are also associated signs and symptoms. Risk factors. As we get older, everything falls off the wagon. So this is just another one of those things. As we age, and then you add on stuff like high blood pressure, obesity, diabetes, heart failure, ischemic heart disease, any cardiac comorbidity is going to tenfold increase our risk here. Chronic kidney disease, and always, always smoking. All right, so good question here. Why do we see so much new onset AFib in a critical care setting? Well, that's a good question. Let's take a look at it. So at the top of our list, we've got atrial remodeling. A lot of people don't know what that is, or maybe have never talked about it, but in a sense, you want to talk about atrial remodeling is a consequence of a lot of different disease processes or things going on. When it's the atrial tissue is remodeled, it's gone through changes over time, just like you change the inside of your house structure. Well, over time, the conduction system that is within those tissues also changes. So you have things that factor in, like heart failure, hypertension, if you've had MI or you've got this like persistent tachycardia, things such as infections, inflammatory responses in that myocardial tissue, all those things over time, they change the structure of that tissue and how it's laid out. And you may think, well, why is that really that important? Well, over time, that remodeling or restructuring can lead to atrial fibrosis. And we know that those tissues, as they become more fibrous, they also change the way that the electrical currents travel through there. So what does that open us up for? That opens us up for all kinds of new excitable points within those atria, which is exactly what AFib is. These foci develop and they develop this abnormal automaticity, so they all start kind of firing from different things. So that's what atrial remodeling is. Next, we also need to think about electrolyte imbalances. So we all know that electrolytes such as potassium, calcium, sodium, these all play a huge important piece in the puzzle of how the electrical conduction system in the heart works. So in people that are critically ill, oftentimes you'll have these imbalances. So we need to make sure that we're monitoring those and making sure that we're correcting them as they are. All right, so next on the list, you've got alterations in sympathetic and parasympathetic activities. So critically ill patients have a war being waged within inside of their body. There is a lot of processes going on, and the sympathetic system is what's kind of gearing your body up for a response. So that's when you're kind of fight or flight, it's what takes you to that point. So it is responsible for releasing catecholamines and kind of gearing your body up for those things. Whereas parasympathetic, it will release acetylcholine to try to get you to a restful state. It wants to take you down. So, there's a fine balance there. But in folks that are critically ill, there's a lot of things happening at one time. And unfortunately, sometimes releasing of these hormones and stuff, they can wreak havoc on myocardial tissue and also can be a contributing factor to AFib. People with greater illness severity often have a higher release of catecholamines, which also leads to progressive autonomic dysfunction. Unfortunately, sometimes when we have a critically ill patient, a lot of times they're on vasopressors. So one downside to vasopressors in the onset of AFib is that it can actually have effects that essentially help cause the AFib, RVR, or just AFib. So the drugs, you look at dopamine, epinephrine, drugs like that, they have chronotropic effects. So that leads to increased rates, and that can increase atrial ectopic discharges, and then that's just a playground for increasing your AFib risk. So a lot of times vasopressors unfortunately carry that side effect. Also want to make sure that we are removing any medicines that could be causing the AFib, such as a beta antagonist. Now, all these things said, minus the atrial remodeling, if we can correct those conditions that maybe help set that AFib in motion, usually it'll be self-terminating once everything is corrected. So a lot of people ask the question, well, is AFib really that dangerous? People live with it all the time. Well, in a short answer, yes, it can be very dangerous. So AFib in critically ill patients oftentimes leads into something called RVR, stands for rapid ventricular response. So not only now is the atria beating fast, but so are the ventricles. And this leads to subpar ventricle filling and can cause hemodynamic instability. In these folks, they have a loss of atrial systole essentially already, and then with the onset of RVR, it just kind of decreases cardiac output and hemodynamic compromise altogether. This is especially important because depending on the patient's severity and how well they're tolerating this is how we're going to treat it whether we use medication or direct cardioversion. So what causes the RVR? So essentially so besides reversible causes for AFib, what else are we going to look at treating AFib with? Yes, medications, antiarrhythmics especially. So here we've got listed out 5 different classes of antiarrhythmics. So let's go through them one at a time. We'll start with 1. Sodium channel blockers. They do exactly what the name says. They inhibit sodium pathways. What is sodium really good at? Helping with electrical conduction in the heart. So if we can inhibit that flow, we're going to slow conduction. Drugs like flecainide are drugs that you won't see a ton in an acute care setting. These are more at-home type drugs, and they're not completely understood as far as the complete mechanism of how they work for the heart. But they do work. I'm not saying anything negative about that. It's just not going to be something in a first-line treatment defense. All right, beta blockers are up next. This is your class 2s. So the nervous system produces chemical messengers. Those messengers get sent out. Your heart beats faster, your blood vessels constrict, airways relax, kidneys have increased production of protein that boosts blood pressure. All these things happen. What are beta blockers doing? Well, they do exactly what the name says. They're going to block those. So all those messengers are going to beta receptors. So beta blockers are going to block those receptors so the chemicals can't get there. So in turn, this is going to help slow the heart rate, and it's also going to help with improving conduction of electrical signals in the heart, relaxing your blood vessels, and lowering your blood pressure. Now, to take it a little bit further, we're going to break beta blockers down even further. There's 3 specific beta receptors. So let's look at beta 1 receptors are mainly heart and kidneys. So what they do is increase rate, increase your pumping force, and activates the release of renin that's found in your kidneys. Beta 2, these are smooth muscle receptors. So these are found in your respiratory system, trachea, bronchial tubes, blood vessels, and nervous system. So a little bit wider spread on these. So these kind of cause an array of things. So causes smooth muscle to relax so people can breathe easier. Causes smooth muscles in the vessels to relax and dilate, that lowers blood pressure. Activates liver conversion of glycogen into glucose, which your body will use for energy. Increases your pumping force and your heart rate. And the nervous system can cause muscle tremors. And then beta 3 is kind of the stepchild. Nobody is really going to be too concerned about beta 3, but I want you to know it's there. These are found mainly in fat cells and in your bladder. So these cause fat cells to break down. They cause relaxation and increase in the bladder capacity, and then can cause tremors, which limits potential for medical applications for B3 targeted medications. All right, so beta blockers as a whole, non-selective and selective. This is how we're going to break them down. And this is going to help you choose what drug may be better suited for your needs. So selective only affect beta 1. Remember beta 1, heart and kidneys, right? Non-selective, these can do effects on beta 1 and beta 2. And if we look at this, I've broken them down into 2. So you've got your selective, which is on the left, cardioselective is how we're going to put it. And then on the right, you've got non-selective. So remember, I put out little people and smiley faces to kind of help you remember what it affects. Cardioselective, heart, kidneys. And then on non-selective, you've got kidneys, lungs, heart, vessels, liver, and nervous system. And remember, on beta blockers, how can you tell it's a beta blocker? Well, it ends in LOL. All of them end in LOL. What is the best suited for AFib and rhythm control? Beta 1, yes, something that's geared specifically for cardiac tissue. Remember, located primarily in the heart and helps block those receptors to slow conduction through the AV node. All right, moving on. Potassium channel blockers. This is amiodarone. This is one that I'm sure a lot of people have heard of. Maybe you've used it, maybe you haven't.
but this is an awesome, awesome antiarrhythmic. So it is a class 3, and it primarily blocks potassium. So inhibiting those pathways where the potassium is flowing during the cardiac cycle leads to prolonged refractory period between the beats. It reduces your cell excitability, and thus it hinders the continuation of tachyarrhythmias, such as AFib, by preventing re-entry mechanisms and ectopic foci. So, along with that, amiodarone also shows to have effect beta 1, calcium, and sodium channels as well. So kind of an all-around hitter. If you've never given amiodarone before, I think it's important to know that when you're given amiodarone, you can give it as a bolus or as a maintenance dose. And most people will give it as a bolus dose first, followed by a maintenance dose thereafter. So if you're doing bolus, 2 doses, 150 milligrams or 300 milligrams, usually given over about 10 minutes. And then after you give your bolus, you would initiate your IV maintenance. And it's going to run at 1 milligram per hour times 6 hours. And then you should transition into a 0.5 milligram per hour until you stop the drip as a whole. Now, there are cases where people have ran the milligram per hour. If the 0.5 is not doing the trick like you want it to, you could get with your provider and they may choose to continue to run it at that 1 milligram per hour, but you just need to be able to watch out for toxicity signs and symptoms. Next group we've got is calcium channel blockers, and just as you guessed it, these are going to be blocking calcium. Calcium is super important in your body because your heart and circulatory system need them to function. So when we use these calcium channel blockers, we're going to show them in 2 different groups, dihydropyridines and non-dihydropyridines. So your first group, dihydropyridines, these target blood vessels, cause them to relax or dilate, and that's why they're so dang good at treating high blood pressure. And if you'll notice, they all end in pene. So amlodipine, nicardipine, clevidipine, etc. Next group, non-dihydropyridines. These are medications that also do blood vessels, but also target heart muscle. So they're effective at heart rhythm problems by slowing conduction. So 2 medications, diltiazem and verapamil. These are 2 important ones. All right, next, cardiac glycosides. They are medicines such as digoxin, who's derived from the plant foxglove. 2 main functions I want you to remember. 1, they block the movement of sodium out of the cells, allowing more calcium to be dumped in. Calcium is important because once that calcium is released and built up, creates a stronger heart pump, making it a positive inotrope. Remember, you can have a positive inotrope, have more squeeze, or negative inotrope and have less squeeze. So this one, positive inotrope. Second thing to remember, cardiac glycosides increase the vagal tone at the AV node. And remember, when we increase the vagal, it slows. So in the case of AFib, that's pretty nice because that's what we're trying to do. By stimulating parasympathetic nerve system, it slows electrical conduction at the AV node. It decreases your heart rate. These are not typically first-line treatments, but we also use them in conjunction with others if they don't work as well. All right, so we talked about medications. What if the medications aren't working? Or what if the patient's that unstable from the beginning and you don't have time for medications? What are you supposed to do then? The patient's just crashing. What are you going to do? Well, if you're thinking about cardioversion, you would be right. You need to make sure your patient has pads on, have your crash cart nearby, and prepare the patient for cardioversion. Usually we're going to start with a stair step of energy. Remember, unstable AFib is going to be a synchronized cardioversion, not a defibrillation. There is a difference. Defibrillation, VFib, VTAC, those types of rhythms. For synchronized cardioversion, your tachyarrhythmias, AFibs, aflutters, that's what you're going to want to set it on. So remember, unstable patients need to be thought about having cardioversion. Cardioversion has a pretty successful first time rate, usually anywhere from 65 to 95% of the patients are going to have a return to normal sinus. Now, whether they stay there or not, now that's the next question. Usually there's going to be about half of them that return back into that rhythm. But it's going to get you to a place where the patient can be more stable and you can have time to figure out what you're going to do about the rest afterwards. Also, something worth talking about. Who knows the term ablation? So for your patients that make it out of the hospital and they're kind of following up with their doctor, if they have continual AFib, medication control, blood thinners, ablation may be something that may be brought up later, and it is a procedure where they go inside, and basically you got these pathways of electrical conduction that aren't normal pathways. So what they go, basically think about, they take a small catheter and they ablate those areas and kind of burn those pathways so where it doesn't connect anymore. And that in itself can help correct these abnormal automaticity from different foci and get your AFib under control.
All right, guys, that was it for AFib. I hope you guys learned something that you didn't know and something you're going to pick up and take with you into your clinical practice and help your patients along the way. So if you learned something, you didn't know it, you haven't subscribed yet, which I don't know why you wouldn't, hit that button, subscribe, help our channel grow, and then otherwise keep up the strong work, and we will see you guys next time.